So here's our first histology slide. And so when you pick up a kidney slide, a lot of the slides, it even looks like a whole kidney is on the slide. You can even see the bean shape to it. If you're looking for so this is a renal corpuscle. If you want to find these, you're going to want to look out closer to the renal cortex because if you remember, I drew a little dotted line right here, and the renal corpuscle, the proximals, the distals, convoluted tubules, those are all located primarily in the cortex, and it's only the loop of Henle that dips down into the medulla. Look in this slide, corpuscle in the cortex, okay? Proximals and distals in the cortex. So you're going to want to look towards the cortex, and you'll see lots of them as you're on low power and you're scanning. It's really hard to miss these big ball structures. And so what do you have to be able to identify? If I have the pointer on this outer layer of this simple squamous epithelium, you can tell me Bowman's capsule, or the parietal layer of the Bowman's capsule. And then, of course, the organ would be the kidney. If I have the pointer, so it's really hard to tell the difference between what are the nuclei of the podocytes versus the nuclei of the simple squamous epithelium of the glomerular capillaries. So if I have the pointer in this tuft of capillaries, you can tell me glomerulus is just fine. So you can tell me the glomerulus. If I have the pointer in the space, right, you would tell me Bowman's space. If I asked, what collects here, you would tell me filtrate. And of course, all of this is coming from the organ, the kidney. Okay, if I have a pointer in this structure and I ask, what is this entire unit called? You would tell me a renal corpuscle of the kidney. So you should be able to tell me the difference between proximal and distal convoluted tubules. And again, if you want to find proximals and distals, they're going to be this image doesn't show it, but they'd be very close to these renal corpuscles because again, look, proximals, distals, and renal corpuscles all in the cortex. So they'll be very close to one another. So how do you tell the difference between proximals and distals? Well, I already mentioned the fact that the first step in urine formation is filtration. You have to filter the blood and stuff has to be pushed out and become filtrate. Well, the way the kidneys work is they dump a whole lot of stuff into the filtrate and then they decide what it is that they want to keep and what do they want to get rid of. So they dump as much stuff as they can out into that filtrate and then will pick and choose what they want to keep later, and that happens in the renal tubule. And in the proximal convoluted tubule, if you remember this picture, simple cuboidal epithelium, almost all of the tubules in the kidney are pretty much simple cuboidal. It's lots and lots of simple cuboidal epithelium. But these proximal have microvilli, okay? And that microvilli, what is microvilli? It's invaginations of the plasma membrane. It increases the surface area, really good for absorption. So the proximal convoluted tubules, look, all of these tubules are simple cuboidal, but it's going to have all of this fuzzy stuff in the lumen. That's all microvilli. And that's because the bulk of tubular reabsorption takes place in the proximal convoluted tubule. So the kidneys dump out as much stuff as they can during filtration, right? Glomerular filtration. And then once that filtrate enters into the proximal, because there's microvilli and increased surface area, stuff will get reabsorbed that the body ultimately wants to keep. Okay? So bulk of tubular reabsorption takes place in the proximal convoluted tubules, and it's because they have all of this microvilli for increased surface area, increased absorption. Okay, so tubular reabsorption proximals. If you look at these that have the D's in them, the lumen is relatively clear or clean on the inside, and that's because the distal convoluted tubules do not have microvilli, and so the bulk of tubular secretion happens in the distal. And what I mean by secretion is stuff that didn't get out at filtration, but our body does want to get rid of, we'll just actively secrete it into the filtrate to eliminate it as urine. Okay, and so that takes place in the distal. So if I have the point, I'm not going to ask proximal or distal unless I have both present so that you can compare and contrast the lumen. So if I have a pointer in one of these, you'll see that as compared to those, they're very fuzzy, lots of microvilli. This is proximal. If I have the pointer in here, proximal convoluted tubule, if I have a pointer in one of these, as compared to those, right, these are relatively clean on the lumen, in the lumen, and so these are distal convoluted tubules, both of the kidney. Loops of Henle, you should be able to identify loops of Henle. The way that I'll ask loops of Henle is in this long, would be like a longitudinal section through a loop of Henle, and portions of the, collecting ducts. Collecting ducts. This would be a longitudinal section through the collecting ducts, simple cuboidal epithelium, and I'll ask it in this longitudinal section, and there's lots of them next to one another. Okay, so collecting duct, simple cuboidal epithelium of the kidney. The bladder, you should be able to identify the bladder on a histology slide. This is relatively easy. You find transitional epithelium, which is also present in the ureters as well, but you don't have to be able to identify ureter. But the bladder, dead giveaway that you're looking at the bladder is this type of epithelium, and this is transitional epithelium. And it's called that because it looks as if it transitions shapes as it moves up, kind of looks somewhat cuboidal, and then they look fluffy and kind of balloon shaped, and then these outer cells, right, that would be on the apical surface, they're really fluffy and balloon shaped, and these are called dome cells. And so the point of having this transitional epithelium in the bladder is because as the bladder stretches when it fills with urine, these having multiple layers, it's a stratified type of epithelium, having multiple layers allows those cells to slide past one another to allow the bladder to expand. And then having these big fluffy dome cells that are balloon shaped on the apical surface, you can envision that they could be compressed as the bladder fills with urine. Now you should, this would be on low magnification, I'm sorry. You'll see that if you were to go up on high magnification up here, this would be all transitional epithelium. You can see that they took a higher magnification image right here. This would all be transitional epithelium. You'll see some connective tissue with blood vessels and all of that good stuff, and then you'll see lots and lots of smooth muscle. And this smooth muscle has a specific name. It's called the detrusor muscle. Now it is smooth muscle, and it's going in, it's in multiple bands in different directions, which allows for the contraction from all angles to help squeeze the bladder when you are eliminating urine. But all of this smooth muscle is the detrusor muscle. So when you look at it, it won't look as pretty as the smooth muscle in the intestines, right? Because in the intestines you have those nice, 2 layers of circular and longitudinal, but here you have lots of layers. You have lots of layers of smooth muscle going in lots of different directions to give the ability to contract in all different directions to eliminate urine. Okay, so you should be able to identify transitional epithelium and the detrusor muscle of the bladder. Now, if I'm asking the detrusor muscle of the bladder, I will make sure that you can see transitional epithelium so that you know that you're in the bladder. This is to show you, so as the ureters come down and they enter into this region called the trigone, okay, and it fills the bladder with urine. The bladder serves as a temporary storage compartment for urine, and then once ready, the bladder will contract and you will eliminate your urine through the urethra. And this is to show you the urethra coming off the inferior side of the bladder and exiting through the urethral orifice. And this is to compare and contrast the length of the urethra in the male versus the length of the urethra in the female. The female has a much shorter urethra, and that's why women are more prone to bladder infections, because bacteria only have to travel a very short distance to get into the bladder, whereas in a male, it's a much longer distance. And then we'll talk the next PowerPoint presentation I put up. We'll talk more in detail about urine formation, and I've already mentioned that there are 3 major steps. We have glomerular filtration, which our blood pressure is the main driving force, and that takes place in the glomerular capillaries. And maintaining that blood pressure comes from having an arteriole coming in, an arteriole leaving, and the fact that the afferent arteriole coming in has a larger diameter than the efferent arteriole leaving. Tubular reabsorption, the bulk of this reabsorption takes place in that proximal convoluted tubule, and that's that microvilli, increased surface area, increased absorption. That's taking all of the stuff that got out into the filtrate, but we really want to save. That's what tubular reabsorption is bringing all that stuff from the filtrate back into the blood. Tubular secretion is anything that didn't get out during filtration, but we want to eliminate as a waste, we do not want to save in our blood, we'll actively secrete it into the renal tubule to be eliminated as urine. So the 3 steps: glomerular filtration, tubular reabsorption, and tubular secretion.